I think I said everything I wanted to say about this slide. Refer to your DASH diet, and your textbook does a nice job of discussing the nutritional therapies, particularly the sodium restrictions. Take a look at the foods that are high in sodium. Okay, these are stages in the evolution of heart failure and then recommended therapy as classified by the ACC and the American Heart Association guidelines. So remember, stage A, this patient is at high risk but has no damage. Stage B, there is some heart disease but no symptoms. Stage C, there is heart disease with prior or current symptoms of heart failure. And in stage D, it's refractory. These patients require specialized intervention. So the stage A interventions are to prevent heart failure. So we're looking at treating the hypertension and all associated risk factors like lipid problems, encourage regular exercise, discourage alcohol intake. I did have a question that came my way about how does alcohol increase blood pressure, and I don't know. I've made a cursory effort to find the answer. I haven't come up with anything yet. But I'll see. If I find the answer, I'll send it out there for you. And then ACE inhibitors are mainstream first-line therapy for patients with heart failure. You remember that interfering with the angiotensin-aldosterone system is very beneficial to patients in heart failure because that aldosterone has a bad effect on the heart muscle, and the angiotensin 2 is that potent vasoconstrictor that makes it hard for the heart to unload. Okay, now in stage B, you've got heart disease, but you're asymptomatic. We're going to do everything we do for stage 1, or stage A, ACE inhibitors again, and then beta blockers in appropriate patients. When people start having symptoms, we do all these things for stage A, and then we add these medications, and pretty much we add all of these if they haven't already been added. Diuretics, ACE inhibitors, beta blockers, DIG, the dietary salt restrictions, and then when those things aren't working and there's refractory heart failure, all measures under A, B, and C. This is where we're looking at the mechanical assist devices like the left ventricular assist devices, heart transplantation. Continuous IV inotropic infusion is palliative, so it doesn't make the patient better. It just helps relieve some of the symptoms. And hospice care is another possibility. Certainly, if the patient's not a heart transplant candidate, hospice care is appropriate. You know, one of the things I wanted to mention about the LVADs, and forgot, is that there have been some patients whose heart function has dramatically improved with an LVAD in place because the LVAD provides the opportunity for that heart muscle to absolutely rest. There have been a few patients who've had LVADs implanted who had their LVADs removed and had good heart function. So that's kind of an interesting side note. There is no way to predict that I know of in whom that might occur, and it's certainly not a recommended therapy. You know, the only reason we do LVADs is for bridge to transplant or as destination therapy. That's just been kind of an aside note. Some nursing diagnoses to consider for this patient population are listed here. And then the interventions, I think we've talked about those in various categories and various places. You should be looking at those and why the patient would have these problems and what we would do about it should flow. Your overall goals in planning is decrease edema, decrease shortness of breath, make exercise tolerable, and I'm not talking about marathon running. We may be talking about walking across their room. We want to make sure that patients can be compliant with their medications, that they've had appropriate education, that they understand why they need the medicines, what each medicine does, under what conditions they should call their healthcare provider about their medicines. And, you know, as much as possible in planning, we don't want the patient to have complications. Health promotion. We're going to prevent heart failure by controlling the underlying heart disease and the risk factors. And then for acute intervention, we're going to manage the symptoms of the acute decompensated heart failures, and we've kind of gone over that already. Ambulatory and home care, we want to teach about the psychologic changes. We want to teach ways that patients can save energy. We want to teach about the medications, and we want to be supporting patients. Okay, cardiomyopathy is in the other chapter that has the inflammatory heart diseases in it. I pulled it out and included it with heart failure because the symptoms that the patient has are heart failure symptoms. So cardiomyopathy describes a function, function of a group of heart muscle diseases that affect the structure. Here we go. It describes a group of heart muscle diseases that affect the structure, or this word function belongs down here, of the myocardium. And I'm not sure why that's messed up. So you just move this word function down here. It describes a group of heart muscle diseases that affect the function or structure of the myocardium. There's 3 types. Most cardiomyopathies are dilated, then is hypertrophic, and the least common are your restrictive cardiomyopathies. Causes. There's lots of different causes of cardiomyopathy. Myocarditis is an inflammation of the heart. In most cases, myocarditis is self-limiting. The patient experiences no consequences. In some cases, myocarditis progresses to cardiomyopathy. I'm personally very familiar with this scenario. A young lady that I know her and her family very, very well developed myocarditis. I believe she was 15 or 16. She ended up needing a heart transplant. She was 23. She was about as close to dead as anybody could be. She was featured on Channel 5. She lives here in Ferguson. And she's been quite a spokesperson for the American Heart Association. She's been on billboards, she and her mom. I don't know if you've seen them. There's a billboard on Interstate 170. And I think the billboard says something like, Barnes Hospital saved my daughter's life. And you see the mom and the daughter there, something like that. Anyway, some other causes include coronary artery disease, your metabolic disorders. There are some cases where pregnant ladies develop cardiomyopathy requiring transplant. Valve disease, ischemic, any muscular dystrophy can affect the heart muscles. Cardiotoxic agents like alcohol, cocaine. This is an anti-cancer drug. There is a genetic link to dilated cardiomyopathy, but there's a much greater genetic link to the second type of cardiomyopathy that we'll talk about. A lot of times cardiomyopathy is idiopathic. We just don't know why it occurs. Characteristics. Probably this is a good place for me to stop again. I'm kind of at 8 minutes, so I will stop and restart.